Let's walk on a journey into the Alberta Diabetes Institute, where we're completely focused on building stem cell therapies to treat diabetes in patients. 25 years ago, we did our very first Edmonton Protocol patient, Brian Best, a teacher who really couldn't function because he had such severe hypoglycemia. He'd been in the middle of a class and basically faint. We gave him one islet transplant and his blood sugars improved dramatically. His insulin requirements reduced by half. That was unexpected, that the first patient would be able to come off insulin. There'd been 273 islet transplants done in the world, and very few of them worked. I did not think the Edmonton Protocol would be any different. And stem cell therapies have come an awfully long way, in parallel with the advances in the Edmonton Protocol over the last 20-25 years. Stem cell therapies can either be patients' own, which is our interest, but we know that's the most ambitious research you can do. You can also make banks of cells that are not patients' own, what are called allogeneic. And what this means for us is that we can now potentially make patients' own cells using stem cells, and we can take a blood sample, that's what we're working on in the lab, from a patient with type 1 or type 2 diabetes, or a patient even that's had surgery and had the pancreas removed. And we can make islets from the blood. It's a very complex process. It involves taking the white cells from the blood, de-differentiating them in a process that makes them into what are called iPS cells. So the question now is, how can we make this kind of treatment, the Edmonton Protocol, more available and more appropriately for patients with less severe diabetes? And our team in the lab is a fairly small team. Dr. Deach and Rena and Heidi and our technicians and graduate students are working incredibly hard to try and solve this puzzle. We work very closely together. If I look back, that team's been working on the stem cell side of it now for about 6 years. We have made phenomenal progress because we began that process from scratch, built a new lab from scratch, and have been able to master the techniques now over the last short while. But that work continues, and it's tough work, but we have to do that in order to reach the first patients. We're continually peering over the cliff face, saying, how can we fund this kind of work? We know it's going to work, but we need that proof of concept. But this is exceedingly ambitious, so we certainly need philanthropy as well to give us the flexibility to move with the ideas as fast as we can as we try to take this stem cell therapy to the clinic.
We're on track for human trials to begin. It's expensive, but with your help, we'll get there soon.
And with that, everyone, I say hello and welcome. You have not missed anything. We started our broadcast early, and if you only got a portion of that video, we're going to try to fit it in during the course of this broadcast so that you can watch it again, because the information is so good, and I know many of you will want to see that. So many of you hopped on very early in the broadcast. You were saying hello. If you haven't already done so, I want to begin just by welcoming to each and every one of you to our 2024 DRIFCan, which is the Diabetes Research Institute Foundation of Canada fundraiser, an evening with Dr. James Shapiro from his lab in Edmonton, Alberta, Canada. As you're settling in to watch right now, please go ahead and introduce yourselves by giving StreamYard permission to use your name. There are so many of you that will know each other on this broadcast. It helps create conversation and community, of course. I want to run through so many of these already. I was bringing up a few of them, and so here they come. Hello from Jennifer Welton. She says, I'm watching with my family in St. John, New Brunswick. We are so excited to learn more about DRIFCan's progress in 2024. I'm Dawn. I live in Los Angeles. Hello to you, Dawn. I'm sure it's a lot warmer where you are than where we are right now. My son has had type 1 diabetes for 11 years. I follow research for functional cures. Dawn, you are going to hear a lot of good news tonight. Kim Morrell is joining us from Prince Albert. She says, I have 2 kids with type 1 diabetes. GDNM says, Dr. Shapiro, could you please discuss the progress of Vertex's VX264 trial? I'm sure he will get to that a little bit later. Matt McLean is joining us from Cochrane, Alberta. The Hams say they are rooting for you, Dr. Shapiro, and they respond, GDNM says everyone is rooting for Dr. Shapiro. I couldn't agree more. Kaylin Hergott from Humboldt, Saskatchewan. Humboldt and area team type 1 diabetes. They are a huge supporter of Dr. Shapiro and his work. And we thank you for that support, and we're glad to have you all with us tonight. Catherine Burbridge from Blackfalds, Alberta, which is southern Alberta. Both of my children have type 1 diabetes. They're adults now, but they were both diagnosed at the age of 6. Jan is coming to you from Calandra, Ontario. I have type 1, 1.5, aka LADA. My son, now 43, has had type 1 since the age of 17 years and 10 months exactly. Boy, so many of these stories tonight. Donald Emery joining us from Calgary tonight. Gord Hendrickson, Cosmopolitan Club of Calgary. Welcome to both of you. Jessica from Sparwood, British Columbia, member of or mom of a teenager with type 1 diabetes. Excited to hear updates from DRIFCan. You're going to like what you're going to hear tonight, Jessica. John McNichol joining. He says, I'm John, hoping to learn and help if I can. John, we are open to all the help you want to give. Mona Lisa, it's Mona Kapoor from Calgary. Hello, medical team. Islet patient and diabetic since 1990. There are a few of the people in my green room from the team that are smiling. They must know you, Mona. Colette says, we have 4 kids with type 1 diabetes. K-Max McDonald, oh boy, she's opened the genie bottle early tonight. Says China said they had a breakthrough where they used a patient's own stem cells to cure a patient. I hope Dr. Shapiro feels this is the proof his method works. Do you know what? We're going to talk about China a lot because Dr. Shapiro just got back from China and he has some huge updates for you tonight. So thank you for bringing that up right now. This is Brett from DC area, America. Welcome to you, Brett. Bonnie from Calgary. I'm islet cell transplant recipient, part of the Edmonton Protocol, now living insulin-free since August of 2023. Congratulations, Bonnie. Sandra Smith from Smithers, British Columbia, diagnosed in 1980. Happy to be here. Rena Galka from Calgary, surgical patient of Dr. Shapiro. Colette from Kelowna, BC. Go, Dr. Shapiro. K-Max McDonald, diabetic since age 16. Paula and Joanne from Red Deer. I've been diabetic since 1973, transplant in 2011, 2013, 2018. Worked for quite some time, waiting for the next steps. They're coming, I promise you. And Ted says, I'm a type 1 and I have been for 53 years. Hello to all of you. Thank you so much for taking the time to introduce yourselves. I try the best I can to get through all of the comments that are coming through fast and furious. Please keep them coming. If I can't read them, I'll bring them up on the screen for you so that it brings the community together. But on that note, it is 6:05. I want to keep our program on track. And I say this to all of you, friends, diabetes patients and your families, doctors, researchers, and scientists joining us from right around the globe. Hello and welcome to our 4th annual virtual fundraiser and evening with Dr. Shapiro. I am personally so excited about tonight because Dr. James Shapiro and his team have so many incredible updates to share with all of you about the progress they have made just within the last year. I'm going to begin tonight by sharing a quick but a monumental story to kick off the evening. It was about a month ago. I was at Dr. Shapiro's diabetes lab here in Edmonton, Alberta, visiting with him, with his team, and with the team from DRIFCan. We were touring his lab. It's undergone some exciting renovations we're going to share with you tonight, and I'm going to let him take care of those details. He also has some new equipment he's going to talk about. I know many of you have been wondering about this. Actually, it was just the other day, a lady's in my Pilates class leaned over and went, "Carrie, I know the DRIFCan broadcast is coming up. Are you going to talk about the new equipment?" Yes, we're going to do that because everybody's excited, wants to hear about it. She was very excited about the broadcast. I have known Dr. Shapiro for well over 20 years. And every time I see him, I ask him the same exact question. And over the years, I usually get the same exact answer or a version of it. This year, however, when I asked him that question, his answer stopped me in my tracks. Any guesses from any of you what my recurrent question is to Dr. Shapiro year after year after year? If you have an idea, pop it in the chat right now and I'll bring it up. Because I ask him the same question every year and I share it with you guys every year. I don't see anything yet, so I'm going to go with it. This is my question. I asked Dr. Shapiro, are we close to a cure? And this year, for the first time ever since I have met Dr. Shapiro, yes, Kimmy, here it comes. There's my question. There it is from all of you. You're all asking. I said, are we close to a cure? So, and for the first time ever, he responded like this. Dr. Shapiro said to me, "This is totally achievable. This is totally going to happen." I honestly get goosebumps sharing that with you because it's monumental. It's monumental for a world-renowned researcher like Dr. Shapiro to use these words. He, like all other researchers, treads lightly around the word cure. Before researchers ever use that word in a sentence, they have to be sure. They need to have seen results that are showing them it's achievable. And tonight, friends, he will tell you it's just a matter of time, and likely a very short period of time with your help. And speaking of time, Dr. Shapiro and his team are accelerating the pace of their research by 10 times. Again, I will let Dr. Shapiro share the details of the 10 times faster planned, the renovations that have happened, the extra staff that is being trained to be able to do more. So now that I've shared all of that exciting news with you, I want you to consider this as we kick off this broadcast tonight. If you or if someone you know is battling diabetes right now, and you are considering making a donation tonight to the cause, would you not want to fund the researcher that is closing in on a cure? Do you want to be part of history where you can say, my donation to the cause helped fund a cure for diabetes? Because, friends, that is what you are doing tonight with your donation. You're helping fund a cure. And when I say fund the researcher, I mean this. When you make a donation to DRIFCan, the Diabetes Research Foundation of Canada, more commonly known as DRIFCan, I just want to be clear on that. Dr. Shapiro and his research team get your money. You're not funding DRIFCan. You are funding Dr. Shapiro's work directly. So let me be 100% clear and transparent on this. If tonight you donate $100, $90 goes directly to Dr. Shapiro and his team. $10 goes to DRIFCan for administration costs. So 10%, that's it. I know there are lots of other foundations out there that are raising money, but how many of them can actually say that they give 90% of the funds that are raised to the researcher that is closing in on a cure? Most will likely say they keep 10% to cover overhead costs. And then the people who have donated, do you know where the other 50% goes? If it's research, then what are they working on with that research? With your DRIFCan donation tonight, you can say with complete assurance, I made $100 donation, if that's what the denomination is, to the person who is closing in on the cure, and he gets $90 of that. How's that for transparency? No other organization in the diabetes fundraising community can make that claim. No one but DRIFCan. So don't you want your money to go to the person who's going to find a cure instead of a random team whom you're not really sure what they're working on and where they're at with it? So many of you make donations to organizations that are important to you because it's the right thing to do. What isn't right is not knowing where your money's going. So I want to stress the transparency and the importance of your donation to DRIFCan tonight. Making a donation, it's never been more important than right now. And here's why. I mentioned this earlier. It came up in the chat. Dr. Shapiro just returned from a trip to China where he visited with the researchers there. I know there's lots of buzz about what China is doing right now in the diabetes community. There are headlines out there that say they found a cure for type 1 diabetes. I will stress this. Dr. Shapiro was always looking to collaborate with others. So he went to China to find out what's happening. I'm going to let him explain the news of what he found, what it all means in just a few minutes when he joins us live from his lab. A little bit of background first. Since we began this virtual fundraiser 4 years ago, we have raised thousands of dollars and interacted with hundreds of thousands of you from around the globe who have supported DRIFCan in its fundraising efforts. So I want to say this, and I stress this on behalf of all of DRIFCan. Thank you, thank you, thank you for your support. We appreciate it so much. We can't do it without you. I also want to share some exciting news tonight. We have a donor from Calgary who has been a huge support of DRIFCan. They have a son with type 1, and they have offered to give us a matching donation of $50,000 tonight for this event. So what exactly does that mean? If tonight we raise $50,000, they are going to match it and give us a $50,000 donation. It's a couple from Calgary, and that's what they are putting on the table tonight. So if you're watching from Calgary tonight, this couple, you're anonymous. Thank you. Thank you so much for your donation. And speaking of donations, keep this in mind. When you make a donation tonight, it can be made in the currency of the country that you live in. You will have the ability to select your currency. And also keep this in mind, you will also get a tax receipt for your donation. It's guaranteed in Canada, it's guaranteed in the United States, and also keep in mind we're coming to the end of the year. Time to consider your tax donations. What better time than now to make a donation? How do you do it? Don't leave us. Open another tab on your computer and go to DRIFCan.com. You can literally make that donation right now. There's no need to wait until the end of the broadcast. Just open that other link and go to DRIFCan.com. Click on it. It is very, very easy to follow. And it will walk you through the steps of how you do that tonight. So yes, tonight is a fundraiser, but think of your donation this way. By making a donation, you are becoming a part of this story, part of the solution and part of the eventual cure. Just imagine a few years from now when a cure is announced, maybe not even a few years, maybe it's a few months. You can tell your friends, your family, and your children, you helped fund Dr. Shapiro's work along with his team who found a cure. You become part of the story and all the lives that are changed because of it. So tonight we're going to take you through Dr. Shapiro's lab. His team, they're all there. I can see them all in the green room. They're working tonight. They're going to give you a live tour. You will see the exciting new technology that you funded with your donations last year. Now, we're also going to talk about the need for patients who want to get involved in upcoming clinical trials. And yes, there is a need. So if you are battling type 1 diabetes and you want to get involved, we will tell you how. Tonight, my friends, is such a rare opportunity because if you or someone you know is living with type 1 diabetes, the information we will share with you tonight could possibly change your life or the life of someone that you love. And what makes tonight so incredibly special is this. Tonight, you have direct access to world-renowned diabetes researcher, Dr. James Shapiro, along with his entire clinical team and research team. And what I mean by direct access is you get to ask the questions tonight in real time, and he is more than willing to answer them. Trust me when I say this, you just don't get opportunities like this to speak to a researcher who already has and continues to change the course of history in the diabetes community. He's extremely busy. He spends countless hours in the lab with his team. Doing interviews like this, I'm going to be honest with you, it isn't exactly his first love. He just wants to focus on his work. But tonight he is making himself available to you to help you understand what he and his team are doing, how they're doing it, and how ultimately you can help. I'm looking at my feed right now. There are so many of you. Oh my goodness. Colette just said, donated, feels good. So many comments come up. I want to introduce Dr. Shapiro, and I'm going to be bringing in your comments as they come available. Start asking your questions tonight. I promise I will get to all of these as they pop up. Before we continue, allow me to briefly introduce myself. And Colette, thank you for your donation. I appreciate you. My name is Carrie Dahl. I was a longtime television news anchor, a medical reporter turned podcast host, and public speaking coach. It is truly my honor to serve as your MC for tonight's virtual event. You know, over the years, as so many of you know, I had the opportunity and the pleasure of interviewing Dr. Shapiro and following his work and his progress. And I am fully confident that one day we will be having a conversation with our kids or our friends saying, I can't believe we used to treat diabetes with insulin. Isn't that wild? Because thanks to his work, insulin will soon become a drug that will gently be placed on the history shelf. I'm confident of that. So tonight, you get to ask all the questions. Where do you do that? You guys have already found this in the comment box. Type your question, keep them coming. I promise I will do my best to get to all of them throughout the course of this broadcast. After my interview with Dr. Shapiro, which will include all your questions, we're going to provide you with some more information about DRIFCan. Rob Otway, the chair of DRIFCan, will join us and update us on how the organization has grown over the years, the pace of research right now, and how your dollars will make a difference. And then following my chat with Rob, you're going to hear from an incredible woman so many of you know and love. Melanie Hibbard will be joining me. Many of you have met her when you were inquiring about DRIFCan. She is their one and only administrative assistant, but she is so much more. She knows literally everything there is to know about the organization and how it works and what Dr. Shapiro and his team are up to. Melanie doesn't just work for DRIFCan. She lives and she breathes it. She also has 2 sons who are living with type 1 diabetes. And believe me when I say this, she wants a cure like so many of you. So bad. After chatting with Melanie, I'm going to bring back Dr. Shapiro. And if any of you have any final questions, I will make sure that they are talked about at this time. I got a nice comment here. Colette says, let's donate every dollar gets us closer to a cure. We can do this. And K-Max says, Melanie is great. Super terrific. Comments are coming through fast. So why don't we kick off the evening with a person that you've been waiting to hear from. He's accomplished, but he's so humble and he's not big on introductions. But I know all of you are interested in his background, and I really believe it's important to give you this information right now. So here comes his bio, if you will. Dr. Shapiro was born in Leeds, England, son of a family doctor. He obtained his MD at the University of Newcastle upon Tyne and trained in surgery at the University of Bristol, UK. James came to Canada in 1993 and completed a surgical fellowship in hepatobiliary oncology and multi-organ transplantation. He completed further surgical fellowships at the University of Maryland, Vancouver, and Kyoto, Japan. He developed a long-standing interest in liver and islet cell transplantation as a medical student and has been working on this for a staggering 40 years. He has been on faculty at the University of Alberta since 1998, where he holds the Canada Research Chair in Transplantation Surgery and Regenerative Medicine and serves as Director, Clinical Islet Transplant Program. He was the lead investigator on the famous Edmonton Protocol islet transplant team for diabetes, and over 770 islet transplants have now been completed locally. This protocol has been replicated in over 1,000 patients at more than 40 international institutions. He was the first in Canada to start clinical trials with human stem cell derived insulin secreting, and most recently carried out the first in-human CRISPR gene edited stem cell islet progenitor transplant in collaboration with ViaCyte and CRISPR Therapeutics, Inc. His current transitional research lab is focused on generating autologous iPS islets for transplantation into patients with diabetes without the need for immunosuppression. And his team and collaborators are working on scale up and manufacturing efficiencies to make this scalable and possible. He is director of the liver transplant, living donor liver transplant, and islet transplant programs at the University of Alberta. He has written 38 book chapters and published over 440 papers in high impact journals, including Lancet and Nature, and his H index is 82. What does that mean? It means a lot of people have read them. His many awards include Hunterian Medal from the Royal College of Surgeons of England and gold medals from the Governor General and from the Royal College of Physicians and Surgeons of Canada. He is a fellow of the Royal Society of Canada and a fellow of the Canadian Academy of Health Sciences and an internationally acclaimed academic leader in the field of transplantation surgery. Friends, it is truly an honor and a privilege to welcome Dr. James Shapiro to our broadcast, joining us live from the University of Alberta in Edmonton, Alberta tonight. And there he is, making his way into the lab. Hi, Dr. Shapiro. You can come on in. They didn't lock you out, did they? We can't hear him yet. Zosha, can I get you to turn on your mic? There we go. He's making his way to his seat as he sits down, and now we get to see him. There he is, Dr. Shapiro. Good evening to you. It is so nice to see you. I was worried there for a second that your colleagues locked you out of your lab.
They sometimes do that. They're always changing the code on me because they know that I can't remember it. So.
Oh boy, anyway, you've got a few other things on your plate tonight and a few other things on your mind at all times. Such a pleasure to see you tonight. Thank you so much for being with us. And tonight is a big night. There are just so many things that you want to talk to us tonight about. Can we begin, first of all, with, before we move and before Zosha takes us on a tour of the lab, can we jump right in and let's talk about the 10 times faster plan? What exactly does that mean?
Sure. Well, before we get to that, Carrie, thanks for making me cry. I wasn't expecting it to feel emotional tonight, but I did when you gave that amazing introduction. But thank you. You know, a few weeks ago I had a conversation with a father in London, England, who is very interested in finding a cure for his son, and he told me it's my fault his 14-year-old son still has diabetes. And that has resonated with me a bit. You know, it's taken us a long time to get to where we are today. I know we're making really good progress, but it's also hard. It's hard for people that face this disease every day. And we don't want to give false hope. We want to give real, solid hope for the future of this disease. That's what we're trying to do. So the 10 times faster approach is, I'm sitting here by one of the hoods. And, you know, I didn't want to have another year go by and another conversation with you and it all be the same old. Things have to change, things have to advance. And I felt that this work is very complex. It requires multiple steps and it requires an enormous amount of time. So how can we move the research faster? First of all, we needed funding. DRIFCan has been amazing. You've been, all have been amazing in helping to support us with what we're trying to do. But we are trying to move this forward now 10 times faster than we have been. And what does that mean? It means we need many more hoods. So I was having technicians and researchers come into the lab. Some of them were starting at 2:30, 3 o'clock in the morning, so they could share the time here in under the hoods to get the work done. So we tried to figure out what are all the bottlenecks in the lab and how can we speed things up. So we came up with a 10x plan. So that meant buying new hoods. We had a little argument with the university as how we could get them all installed and change the lab around a bit, but we managed to succeed with that. And here we are today in the lab. We've got some amazing renovations done here, and we can probably walk around now if you want to and get Zosha to show you.
I'm going to bring Zosha in, and she's going to take us on a tour. So you go ahead, because the bottom line of this, Dr. Shapiro, is the donations funded these changes. So tell us about that. Tell us what we're seeing.
So you're looking at a quarter of the lab, which was what basically we had before. And this is the limited space with the double hood here and the single hood there, and where Heidi is behind us, a microscope. But we needed to find a way to get more technicians working faster, to get more work done, more research done, so that we can get to the end faster. So Zosha's going to walk you to the other end of the lab now, and you're going to see a whole new section. So we've got a whole immense. We've got new incubators. Yes. Those are the incubators. We've got new hoods. Now I know it all looks like the same as what you've just seen on this side, but what I want to pause you there. Now,
I was there a month ago, and it was an open wall. There was nothing.
Yes, you're absolutely right. So no, it's not an open wall now. There's Nadish sitting by one of the hoods. Nadish, why don't you join in here and tell us from your point of view what these new hoods are going to do for us.
Hi, Nadish. Welcome.
Hi, Carrie. It's a pleasure to meet you again in 2024. It's been a phenomenal journey for over the many years with you and with James. You can see the excitement on my face. How does that look and how does it feel while having the newly renovated lab space? As James mentioned, we started with a very small room, moved to 2 little hoods now that you have previously seen, and now this is a new extension. So we have additional 3 more hoods. We have 5 working stations. What does that mean is we have more people to come in, do the cell processing in the real time, and we can produce larger amount of cell mass that can be used for testing in animals and in vitro studies, and we can move faster to see which process is most optimal in order to produce clinical grade islet cells. We can rapidly translate it to GMP manufacturing and move to a clinical trial in real. So this resource and all these equipments are so important and beneficial for us to do a step 1 and do the cell processing, so we can rapidly move faster in the next few months to a year time.
Carrie, sorry to interrupt, Carrie, just to make the point ultra clear for everybody. So when we start with this, we start with a blood sample, and then we make these special kind of stem cells, the iPS cells from the blood, and then we go through a differentiation step, and that whole step takes 2 to 3 months every time we start it and end it. And in order to learn and advance these protocols, we can't just do one experiment and wait 3 months and then get to the end of it and then start again. We need to run experiments in parallel. So that's why we've gone from these 2 hoods that we had initially to 5, and our ability now to move this forward 10x will get us there faster.
Do you have some cells, I think, on the computer that you were just talking about? Zosha can hear me. If you can go to that computer screen, give us an idea of what we're looking at.
Okay, Zosha, we've got some IP. Those are the. Can we hear you, Zosha?
Yes, I hope you can hear me.
Yeah, we can hear you, Zosha.
Yeah. Okay, perfect. Yes, so on the screen we have a photo of some of the starting cell material. and what these cells look like originally when they're just growing and they're just stem cells. And then over the course of the time, this is the process of how we derive these stem cells. So we collect blood from a patient, like Dr. Shapiro mentioned. We can isolate specific clones and turn those clones into specific stem cells of that patient, and then mature those cells and differentiate them into islet-like cells. And here's an example on this microscope of what those end up looking like. And in the process along the way, they grow in these 3D suspension conditions. And so there's an example of a smaller one here next to Heidi. And sometimes we can also work at scaling this technology up. And to give you an example of what that looks like when they're growing, we can pop into one of these incubators here. And so there's some of our actual cells that are currently spinning away and differentiating towards islets.
And what, I just want to mention that because every single technician who is producing these cells, they have to sit for hours and hours to do the cell processing in each station. So in order to have multiple technicians doing the work in real time, it is good to have those stations so that we can work simultaneously without waiting for long hours, right? And that's why I think having this lab extension is just great help.
I want to ask, when you talk about cells, now we are talking about growing cells, islet cells, correct? When you are referring to the cells on those screen, can one of you clarify what that means exactly for the advancement of this treatment?
So we're starting off with blood stem cells, and we have to expand them, and we have to turn the blood cells into the stem cells. So right now we use what are called viral vectors, a special kind of viruses that basically decode the cell and take the brakes off it to allow it to become, well, let me put it really simply. When you're a tiny embryo, or like a pinhead, you have 2 cells, 4 cells, 8 cells, they divide. And as you divide, at the beginning, those cells can become any cell in the body. And that's what we start with. That's what we're trying to do at the beginning. We're trying to make any cell in the body. And once we've got to that point, then we want to tell those cells, no, we don't want you to be anything. We want you to be the cells that will potentially cure diabetes. We want them to be insulin-producing cells. So then we have to coax those cells with adding different growth factors every day to mimic the conditions that would happen inside a tiny embryo. So that it takes 27 days to make islets inside a pancreas for any of us before we're born, first 27 days of development. So that's what we're trying to do to start with in the lab, is take the stem cells, make them, take the blood cells, take them in, turn them into these malleable cells, the iPS cells, and then we're trying to move them forward, coax them into being the insulin-producing cells. And we do that by adding these growth factors. So all of that happens in the incubators or under the hoods here. The growth factors are added under the hoods. The incubators are there for stirring the cells, mixing them up, and allowing the growth factors to act. And then we spend a lot of time under the microscope looking at different samples. So maybe, Saoirse, you could show us the Thunder Imager and maybe walk us through what that can do.
Yeah, so this is the Thunder Imager. This is one of our newer pieces of technology. I have to stand quite a ways back to capture the whole thing, actually. But this is a pretty unique microscope to have in Alberta because it lets us do live cell imaging. And so, for example, we can put cells into a container here and they can be perfused as though they're in one of those incubators the whole time. And we can image them under here in the dark. We have some slides in here right now, so we can do fluorescent imaging, we can do bright field imaging. And so we image these cells at different stages of development. We can image them live as they're just developing into those stem cells and look at which ones will be the best candidates for turning into islets. And then we can stain some of these slides that you saw under here. I'll give you an example of some of them. And these are tissues that we harvested after some of our transplants, and now we're looking at specific markers under there to see if our islets have developed and matured and what they look like. And so on the screen here is an example. These green cells that you're seeing are positive insulin stained cells that have grown in an animal after transplant, and those came from stem cells that we made right here in the lab.
Oh my gosh. Oh my gosh. Like, that's mind-blowing to me. Absolutely mind-blowing. So that was I wanted to pause there and ask, this is the work you're doing now. What are you finding? Where are you at with growing these cells for transplantation into patients?
Well, what we've shown, I think, very clearly is we can make these cells. We can follow the protocols that we've learned from other people, and we've had you talked about collaboration at the beginning, and we wouldn't even be able to start this work if we hadn't had amazing collaboration from scientists right around the world. Whenever we ask, the doors open. So we can approach labs and scientists right around the world. We can ask for help, and we learn from them. So we've developed our own protocols and our own modifications, but they're built upon the success that the other scientists have developed and proven. And it just makes us realize, we live in a big world, but it's actually a very small community of scientists working together and collaborating to allow us all to get to the next stages that will allow our patients to be treated and potentially cured one day. So there's an amazing collaboration that goes on, and it's all because we're able to learn from others and advance things ourselves and test in our own lab.
Well, that collaboration, as you just so eloquently pointed out, is so key in the progress of and treatment and the steps toward finding a cure. Before I jump into questions about China, I don't want to leave the lab just yet. Nadisha is still with us. So what you gave us a tour of, we're seeing all of these hoods. You call them the hoods, but that is allowing many more researchers to come in and work. It looks like they're all the same, but you didn't have that number. What was last year when we talked, you had what, 2 or 3? And now you have 7, is that correct? Give us the numbers and how this is helping your team as a whole to speed up the progress and get closer and closer to a cure.
Yeah, I think we have expanded our team. Previously, we had only myself and Rena and Heidi, 3 technicians. Right now, we have hired 3 more technicians, so we are total a team of 7, people in the lab. And there you see Dominic and Cassidy and Heidi and Rena. So we all can have a flexibility to work on these stations, do the cell processing in parallel without waiting for each other, as well as the backend team, like, we just got Cassidy and Dominic. They can help performing the real-time quality control of these cells so that we can take daily decisions, important decisions, whether we need to move forward, we need to take a step back, or what do we have to do with these cells, so that we can move forward to a very definitive goal and take right steps in order to optimize the entire manufacturing process for clinical grade manufacturing. So this is very critical for us, having a big team, and I'm delighted that we are expanding.
It's so great to see all your faces tonight. Thank you all so much for joining us. I know your mic's on mute. I'm going to get you to take them off so Dr. Shapiro and I, Nadish, we can all have a conversation together. Rena, I know you've been a part of the team for a while now. What is it like for you to see the changes you have even in the past year? I think you're figuring out how to unmute yourself. You got it? There you go. Exciting changes in the last year. Tell us. Okay, Rena, I'm going to pause you. We can't hear you right now. I'm going to come back to you. So hold that thought. You're having problems with your mic. Maybe Heidi wants to jump in. Heidi, you're smiling ear to ear. You're grinning. So tell me about the changes you've seen in the past year, what it means to you.
First of all, can you hear me okay?
We can hear you great.
Okay. Well, I first want to give a big hello to all your viewers, and it's a pleasure to speak to you all. And yes, I have to say that we are quite excited because like Dr. Shapiro and Dr. Dadich mentioned, our lab has increased significantly, and we really needed that help because there's just so much to do. And with the help of our new technicians, we could do so much more and faster and better. And there's just all these little things that we have to always monitor and take care of. And it takes time, and it's really hard for the 4 of us to carry that huge load. So I'm very excited to have them here. I'm very excited to have the new equipment makes life a lot easier. So yes.
Thank you. Thank you for sharing your thoughts, and your enthusiasm is palpable. I know that's exciting for you. Zosha, what does it mean to be part of this team? I know you're a graduate student. What was it like when you got invited to join this team and to do this type of work?
It's been great. I've been here, well, I've only been here formally for just about a year and a half now, but I was actually part of Dr. Shapiro's lab way earlier. Back when I was in high school, I got trapped here a little bit. And then I am also a surgical resident, so I work with Dr. Shapiro clinically, and it's a really wonderful pleasure to be able to step outside of the clinical sphere and be able to be in the lab and see things from both a patient perspective in the hospital, and then come here and work so hard behind the scenes with everyone here to try to develop better therapies for them and advance the medicine that we have available.
Thank you, Zosha. Friends that are watching, like, this is your surgical and research team here. If you have questions, put them up in the chat, because the access you're getting to them tonight is truly unprecedented. So if you have anything you're wondering, please let me know, post your comments, and I will take your questions to them. Rena, can we hear you yet? If you try to unmute yourself again, let's see if your mic is working yet. Say hello.
Hi.
There you are. Yes.
Well, first off, thank you, everyone, for joining us tonight, and it's a pleasure to talk with you and to have you interested in the research that we do day in and day out. I've worked with Dr. Shapiro for over 20 years now, and I have to say that this research is the most exciting that I've worked with in the past 20 years. To think that we can take as simple as a blood draw from a person that usually goes to the Canadian Blood Bank or whatever to get that blood draw, and then bring it back, reprogram those cells into insulin-producing cells, which can then be transplanted, is really a step into the future. I don't think we're the only ones that are working towards this. We know the potential that there is. And having someone personally affected in my family with type 1 diabetes, my older sister passed away at the age of 49 due to complications with diabetes, type 1 diabetes. So I have a personal drive for this research, and I also have a professional drive as a scientist to move this research forward. So thank you very much for your donations. Thank you for your time this evening. And I do all the purchasing for the lab, so I know the expense that goes along with the research. And the materials are expensive. This is new, exciting research, and as such, hopefully over time it will become less expensive. But right now, it's an expensive process, and it's a time-consuming process with a lot of manpower. So thank you.
Thank you for your contributions and for giving us that perspective tonight. Okay, we have some questions coming in. I'm going to let a few of you relax in the green room right now. Thank you, team, for joining us. I am going to keep Nadish and Dr. Shapiro with me tonight. Here's a few questions that are coming in, and perhaps you can go ahead. We'll try to, here we go. From R, it says, is there a ballpark date of when we will find, or when a cure will be found? Will immune suppression, anti-rejection drugs be required? If so, for how long? Thank you. I am grateful to you all.
Well, I wish I could put a calendar on the wall, stick a pin in it, and say this is the date when it will happen. Unfortunately, we're only as good as our last experiment and as our last lot of cells that we've made. So that's why it is so hard to nail down an exact date. It's the hardest question, probably the hardest question I'll be asked tonight. Why is it taking so long? How long will it be? What's the date? Is it 5 years? Is it 10 years? How long do we have to wait? We have to wait until we have a cell product that is safe, that is effective, that is proven, and that's a stepwise process in itself. So we're talking about the first few patients that are treated, then we can talk about the first 10 or 12 patients that are treated, then we can talk about the first 100, and then maybe 1,000 patients that are treated. I think we have to think of it in those terms. People hold up banner and say the cure is found. It doesn't work that way in practice. From my perspective, it has to be stepwise. We have to be sure that we have a product that is safe, and then that it works and that it's durable. And that's why how long it takes is such a tough question. We will work as hard as we can. You've met the team tonight. You know, if they're working day and night. This is an incredible team. They're working really hard to get those cells growing in the incubators, to make sure the growth factors are right, to make sure all the protocols are followed. And these are probably the most complex, they are by far the most complex protocols that we've ever had to deal with. So it's an immense amount of work, but we're not shy of work. We're not frightened of it. We'll work hard and we'll work harder and we will get there.
We have another great question coming tonight. It says, is Vertex's VX264 trial working? How long ago was the first patient dosed in your lab?
Okay, well, I don't have the exact data at my fingertips, but so the VX264 it involves transplanting cells from a company called Vertex. These are the same kind of cells they've been using in their other trial where patients have come off insulin, VX880. These are insulin-producing stem cells, and they're placed within a biological membrane that shields them from immune attack. So those cells are being put deep in the abdominal wall, just below the deep below the muscle, but just before you get into the peritoneal cavity. It's called the properitoneal space, and it requires a surgical procedure, and a number of discs have to be put in. We did our first transplant with that trial about a year and a half ago. There are, I think, about 3 patients treated in the world right now with that. It's an ongoing, slow process. We have not analyzed the preliminary data at this point. It's actually all locked away in Vertex, so I'm not at liberty, nor do I have knowledge of the current data in it. But it's an ongoing trial. We're highly interested in the results, as I know you, many people on this event are interested. We will be able to do a transplant with no immunosuppression, with cells implanted in a different space. It's a lot to ask in an experiment, in a clinical trial, but it's an ongoing trial, and I don't have all the answers at this point. They will come.
You've been nodding your head in agreement with Dr. Shapiro. Is there anything you want to add in on what he said? Because I know the two of you work very closely together.
Yeah, I think I completely agree with James, what he said. And, those trials are in very infancy right now. I think we need a very deeper understanding to really assign, like, what kind of effects are we seeing from those cells, those encapsulated and transplanted in patients without immunosuppression. It's so early to see that. I don't have any detailed insights from the hospital itself, but what I can tell from my experience is, yes, there's a big team that is working in the back end from Vertex, as well as from our side in the University of Alberta, and we will collectively look that together in later time, and to come up with the right results. So I think James is the right person who can really update in coming few months or year time.
Okay, Nadish, thank you for your perspective. I'm going to let you relax in the green room for a while. And Dr. Shapiro, I'm going to ask you what a lot of people want to hear about tonight is your trip to China. Tell us about why you went, what you found, and what China is doing, and how their lab is the same or different than yours. I'll just let you go from here.
Well, we read a paper recently actually 2 papers from 2 different groups in China. One from the group in Shanghai, and another group in just in Tongji University, just outside of Beijing. And because of the collaborative spirit that we've talked about, within hours and days of those papers coming out, I contacted both scientists, and both of the lead scientists welcomed us in to learn more about what they've been doing. We had detailed discussions lab to lab about their approach and process. And at that meeting, they said, well, why don't you come over to China and visit? We've got an international meeting going on, the Asian Pancreas and Islet Transplant Association meeting. Would you come in a few weeks? And normally I don't travel. I try to stay at home, got a young family, want to stay put. But the this was too tempting, and it also happened to be on a week when I was free. I wasn't on transplant call, I wasn't on surgery call, so I absolutely said yes. And so the last time I went to China, hopefully you can see that picture.
Oh.
Let me see. So well, I'll bring it back. So that was me 40 years ago with my very first patient that I did surgery with in Shanghai at the
Wow.
First People's Hospital there. That was in June 1985. I know it dates me. You can tell from the length of my hair, I suppose. But so she had appendicitis. I took out her appendix as a medical student, and she survived, and that was my first journey in surgery. And then 40 years later, that's me in the same hospital, probably a bit blurred for you, there you are, Shanghai General Hospital. And just a few weeks ago, and they made me incredibly welcome. They took me back to the original teams. I was able to see the advances in surgery that have happened in the last 40 years. And then we spent quite a bit of time with the scientists that have been involved with both of those trials. So I was really happy to be part of that. So this was the first paper that we read. It was yeah. So this is a patient with type 2 diabetes, and they basically did exactly what we've been talking about doing in this lab, making stem cells from patients' blood, autologous, meaning the patient's own cells, and then they transplanted them back with the idea that they would be completely protected and not attacked by the immune system. Now, I guess just because of the way things work in China, they happen to pick some very complicated patients to start with. The patients that were chosen for these trials either had liver transplants or kidney transplants, so the patients needed anti-rejection drugs anyway to maintain the function of the liver or the kidney transplant. So these autologous cells, the patient's own cells that were making insulin, were kind of added on top. So we recognize that for various reasons, they had to pick complex patients to start with. I suppose because these patients were so desperate and so, had no other choices. So it was absolutely amazing. It blew my mind away. These patients were off insulin. This first patient in this trial was off insulin is off insulin for 3 years. And they've done 2 more patients in that group. So that's a total of 3 patients in the Shanghai group, all of whom are off insulin. Now, the second patient they did was a patient who had type 1 diabetes. And what they found with the autologous cells, which is something we've been worried about over the course of time and talked about too, is that the immune system could come back and attack the newly transplanted cells in somebody with type 1 or autoimmune disease. And that's what happened in the second patient that they treated. They gave that patient another transplant with some additional anti-rejection drugs, and that the patient's off insulin is excellent. Like, these patients have got, how to put this? So the patients wear a continuous glucose monitor. It measures the glucose level in the blood 24/7 across a constant timeline. These patients have 100% time in range, meaning that they have absolutely perfect sugar control off insulin. So basically, these patients have become normal individuals. They don't have diabetes anymore. I think we can say that. And we can say that it lasts at least 3 years. We have to wait and see if it'll last longer. I think it will. But we've learned an awful lot from these studies. And the same thing happened in the group in Chongqing, which is outside of Beijing. So they worked, and this is the second paper that we read published in Cell. I'll try and put that one up for you. It's probably a bit blurry. There you go. You can just about see it. So this was a patient. This is probably the one that caught most of the attention of people on the call tonight. This is a patient with type 1 diabetes, where the cells this time were placed inside the muscle there on the it's called the rectus muscle, the muscle on the tummy wall. And the reason they picked that was because this patient had had 2 previous difficult liver transplants and a pancreas transplant, really a very difficult tummy to work in surgically. So they put the cells inside the muscle layers of the rectus sheath. One of the things that I've been a bit doubtful about when I first read these papers and from previously was how real would the data be from China? It's a long way away from us. Is it real? Is it robust data? And I was, I think, very convinced by talking to the scientists. I was even more convinced when I visited the labs and was able to see with my own eyes exactly what they've done. I learned that the regulations for these labs are probably a lot stricter than they are here in North America. So here is this is the GMP lab for the for one of the companies
Wow.
called Endocell. So you can see we're visitors, but we're inside a central console there, looking at the screens for the manufacturing facilities. And then when we go to the manufacturing facility itself, you can see the GMP environment, ultra clean room environment where the scientists are working to prepare the human cells. And this is all filmed in real time in the lab. You know, this is real. This is really happening, and these scientists are generating amazing cells. The second place I visited, this was about a 5.5-hour drive from Shanghai, in a place called Hongzhou. So this is another manufacturing facility where they make stem cells from patients' fat. It's a different process. It's slightly different, but it works amazingly well. So early days, but these groups have validated essentially the concept that we've been working on here for autologous therapy. They have not yet tested, as far as I know, tested in patients that have no immunosuppression at all, which is where we want to be one day. And we would probably get there stepwise. We know that we have to do something to switch off the autoimmunity for patients with type 1 diabetes, but we are, I think, exceedingly encouraged by these results. To see patients with such perfect sugar control off insulin is absolutely mind-blowing. It's stunning.
So, Dr. Shapiro, your takeaways from this trip, I guess what's important to stress here is these patients, we can't call this a cure because they're still on anti-rejection drugs, correct?
They are, but the concept is there. The concept that we've been working on with the autologous cells is there. And they've in some ways, they've and this is fine, they've jumped two or three stages ahead of us, which is, you know, now we have to learn and speed up and see how we can move this process in the lab forward faster so that we too can begin the clinical trials in patients just like they've done. And I anticipate that we'll be able to do that, but I think we need to learn from them. I think we have to collaborate very strongly with them in order to do that, because they've done all the hard work over the last several years as well. But I'm very hopeful for this approach. It really endorses the concept. But you're right; they haven't got to the end stage yet.
So what will you be doing differently now after learning that information? This will affect your clinical trials, and how?
It's going to affect us immensely. I think that, you know, Nidish and I and the team have got to sit down and think very carefully. Are the processes that we've been building in place right now sufficient? Are there some better approaches and advances out there that would simplify the process and allow us to get to GMP manufacturing and safe clinical transplants faster? Do we need to do this together with the team in China? Do we need to add our own advances to that? And I think that those will evolve over the course of time.
Some questions, if you will, Dr. Shapiro. We have Row House says, since a cure ballpark is hard to give, what about a human trial start? If funding were sufficient, could a human trial start within 12 to 18 months?
If we had all of the know-how that the Chinese groups have tomorrow, like meaning the entire recipe with all the secret parts, secret sauce, and all the rest of it, if we had that tomorrow and we had sufficient funding, we could begin the GMP manufacture, the validation testing, and within 12 to 18 months could start clinical trials. That would be a very ambitious timeline, but in theory it's possible. We have done clinical trials before with relatively short timeframes. We recognize this will be a complex one to take through Health Canada, but there's a lot of preliminary work that would justify it. So I think it's not unreasonable to think about that kind of timeline.
Okay, let's address the white elephant in the room. If you are thinking of that timeline and you get through with Health Canada, there's got to be a funding element to all of this.
Absolutely. So you know, you'd like an answer of what's it going to cost us to do those trials?
Yes.
And you know, a ballpark, we've on the back of the envelope kind of calculations, we estimate will take about $10 million to get to the first 10 or 12 patients treated. Could be more than that, but we've got to map the processes that are being used in China against our costs here. We've got to be sure that the reagents are all available and that the GMP facilities can be accessed to manufacture. So these are very rough estimates at this time. There's no question it's going to be costly for the first patients treated. But is it worth it? Absolutely, because if we can validate that here, these costs will come down immensely, dramatically, as more and more patients are treated, as these reagents and the protocols become more standardized. So I'm less worried about the costs of the initial trials, although it's going to be a challenge to raise that kind of money.
And it obvious the tour that you took us on, how many pieces of equipment in your lab were funded by DRIFCan and, all of the fundraising from the last year, do you think?
Virtually all of this lab is funded by DRIFCan, because the grants, the other external grants that we get cover some experiments, but they don't cover equipment. So all of this lab basically, and the technician salaries mostly are covered by DRIFCan. So without DRIFCan, we wouldn't have a lab.
And that's to all of you watching. Now you know where your dollars are going to and how close they're getting. Colette says, 10 million, let's go. We're going to talk about that a little bit later, about the 10 million. A question from Kimmy Morale. Are you or anyone trying to find a way to find a cure that doesn't involve having to take immunosuppressing drugs afterward?
Absolutely. That's exactly what this work is about, making patients' own cells. So my day job is a transplant surgeon. I do liver transplants. So I know when I do a liver transplant for a patient, they have to take anti-rejection drugs for the rest of their lives in order for the organ not to be rejected. Same thing with the kidney, same thing with the pancreas. Now, in this situation, if we put patients' own cells in, they will not need anti-rejection drugs to allow the survival of the cell. So if we do this in patients with type 2 diabetes, we won't need any anti-rejection drugs at all. In patients with type 1 diabetes, you won't need long-lasting full-dose anti-rejection drugs like we have to give for an organ transplant. You will need something to reset the immune system and make you less susceptible to autoimmunity. So what does that mean? So if we were to start these trials tomorrow, it would probably mean us giving a quarter of the dose of the anti-rejection drugs that we would give to a standard organ transplant or to an islet cell transplant patient. What does that mean? A quarter of the dose means a dramatic reduction in the risk of cancer, infections, off-target side effects. So it means that this would be a lot safer to transplant a child than it would be with the previous cells, the organ donor transplant cells, the Edmonton Protocol type cells. So safer. We'd like to get to the point where we need no anti-rejection drugs, but we know we'll need something right now, and it will probably be some kind of immune reset, or it will be an antibody, a biological agent that's given at the beginning to prevent autoimmunity from occurring. And there's a lot of progress in that area happening in other parts of science right now and in clinical trials. So I imagine and I envisage that this work will dovetail the work that's being done in prevention and reversal of autoimmunity in type 1 diabetes. These two will go hand in hand.
A question from Mark Sabri says, what sort of patient parameters are you looking for in test patients? And he says, good luck.
Thanks, Mark. So I think for the first patients that we treat, we're going to look for relatively straightforward patients that are not as complicated as the patients treated in China. We don't want patients with previous multiple organ transplants and other disease states that would make them high risk. We want to take patients with relatively stable type 1 diabetes that are well informed, can understand the potential risks involved with a transplant and the potential risks known and unknown from these new therapies. And if they're willing to take those on board, then I think we would be willing to work them up. That's sort of where we stand.
Okay, one more question, because I know you probably need an opportunity to catch your breath here. This one says, are the last two roadblocks supply of insulin-producing cells and the immunosuppressing drugs? Which of those two are closer to being solved? Are they both close to being solved?
I think the autologous therapies that we're working on address both of those streams. So they address the supply of insulin-producing cells, because with the stem cell, it's like a photocopier. You just have to put the paper in the beginning, you have to put the ink, you press the green button, and out come the cells. It's obviously not as simple as that, but you can basically make as many stem cells as you want using that approach. It's like a photocopier. It's far more
Okay.
complex. I've simplified it,
Right.
but it's like that. But in the same thing with the autoimmunity, I think we're going to learn from these trials will help us probably reset the immune system for other patients that are at risk of getting diabetes.
One more question here I have to squeeze in. Mark McKay from Calgary says, thank you, Dr. Shapiro and your team for all that you're doing. When do you think clinical trials will start, and how will you select people to participate in those trials?
I'll show you an email that I got a few weeks ago. Maybe you can read that. Yeah. So,
read it to us.
It says, hello, I'm just wondering if you were allowed to do the diabetes stem cell thing, how you cured it in rats. And I remember you said there was a lot of red tape. Well, could we just go into the ocean and do it, or meeting Mexico, and I'll be the first guinea pig? That's fine. I really can't live with diabetes much longer. So can we do it somehow? Well, I get a lot of emails like that one. And what's behind it? You know, patients are desperate. They have lived with diabetes long enough. They want something better. They want something different. My job is to do the next stage very carefully. I can't rush ahead on a ship in the middle of the Pacific Ocean and do a transplant. We could do that, but it wouldn't be the right thing to do. We have to make sure that our cells are safe, that they follow all the local regulations, that they follow Health Canada regulations, and that we do everything as safe as we can. So, you know, I recognize the need. I recognize the desperation and how brave patients are coming forward like that. But we've also got to do it right, because if we don't do it right, we could really slow the progress forward.
Dr. Shapiro, I've had you talking for probably about 45 minutes right now. I'm going to let you catch your breath and take a break and get some water. And I'm going to move on to a few of the members from DRIFCan to chat with them a bit, and then we'll bring you back for closing questions. Thank you so much. There really is like hundreds of questions we could ask you, but I think the core of it is how close you are getting, your collaboration with China, what you have learned. And I mean, we're just so grateful for all of the work that you have done to date. So go get a glass of water, relax, and we'll talk to you in a bit, okay? Thank you so much. Wow, that is it's mind-blowing when you listen to the amount of progress that has been done in the last year, that has been made in the lab, that his researchers and Dr. Shapiro were talking about. And I want to continue this conversation by welcoming Rob Otway to the broadcast. He is the chair of the DRIFCan board and also recently retired CEO and executive vice president of Bird Construction. Congratulations on the big change in life, first of all. How's it all going? You're still probably as busy as always, Rob.
Yes, I'm joining the ranks where they exactly say the same thing, and busier now than when you were working. One small clarification, I wasn't CEO, although perhaps I might have aspired to, but executive.
Okay. Thank you for that, Rob. Your reaction, I was kind of watching all of you in the green room, watching a lot of things going on when Dr. Shapiro was talking, and talking about a cure is within sight and his recent trip to China. What is your reaction to that? And from the perspective of DRIFCan, what kinds of perspective would you offer tonight?
Well, you know, it's been a journey for me too, to learn all about research and the process and the specifics about diabetes and this disease. But you hit it on the head right off the bat. Like for many years, I've been involved with this about 6 years. We've had the same kind of very cautious response, and we all understand why, from the research team. And but this year has changed quite a bit, and Melanie will talk about that too. We've noticed a real change in approach, in not so much attitude, but in terms of like time is ticking, and we've got to amp this thing up. And at the same time, more willing to say that, you know, it's not 5 years off, it's not 10, it's not. It's close, and it's very close. So my reaction, and I was fascinated watching this, because each time I learn more about this, is that we collectively, like the diabetes community is amazing. And I'll say that to the people that are on this call or watch it later. And it knows no borders. Like our organization has truly become international over the last year, maybe 18 months or so. And we're getting support from people across Canada, from people in the States, and starting to get interest from UAE and Singapore and other places. Uh, and you wonder why, because they could probably support research in their own areas, but I think people are really keen to support all of it, but teams that are making progress here.
Yeah.
And my reaction to all of this is that we have got to hurry up, raise more money. And obviously, like not everyone on this call is capable of donating and things like that. But I think the message I want to give people is everyone knows someone that can help, either financially or spread the word, or we have to stop being, the best kept secret on the planet if we're going to make true progress here. And I know even yourself, I've heard through the back channels that you had some discussions with some friends, and lo and behold, they had type 1 child, and before we know it, we're having a conversation with them. Exactly how it has to work, because we don't need a large organization or a large board. What we need is a large group of supporters around us that are connected to the broader world, right?
And
that's what works.
What you say is so key, and sorry to interrupt you, Rob, but I want to piggyback on what you're saying, is because, like how you said, we all know someone, and someone knows someone. And what I mean by that is, when Dr. Shapiro said, because people are asking, how much do you need to get it across the finish line? $10 million. Well, we may not have $10 million, but someone may know someone, and there's a lot of people out there that are looking to park tax dollars, that are looking to fund an organization, that have come into wealth or have means, and they want to make a difference. And what better way to be able to say, I helped Dr. Shapiro and his team find a cure with my donation. They exist. They're out there. You've been in the business community for many years.
Absolutely. Absolutely. I mean, it's relatively easy to raise money for investments, right? Where someone's going to make a return and a financial return on it. But it's much, much more difficult when there is no guarantee that your money is actually going to get a return in the sense of an actual next step to a cure. But so it's high risk in some, but very high reward as well.
Yes.
And the frustrating thing, I think, from my perspective, is we're out trying to raise money and for a very good cause, as are others. There's not a lot of government or type of support for this. They'll come in later and they'll fund it later when it's soon. And I think I understand why. It's like a startup in many ways. But if we don't put our shoulders into it, I don't know when this is going to happen. And so I go back to, you look at what's happening in China, and I think there's probably good results happening in other parts of the world. The beautiful thing is people will trade information on this to accelerate this whole process. And there's likely going to be many different paths discovered to make a practical cure at the end of the day. I'm not a scientist. I don't know. But I do believe we're on a very good path that will yield great results. We talked about the anti-rejection drugs and things like that. It's so key. But we need to put our shoulders into this first 10 million. There'll be another 40 to 50 after that to get through the next round to build some of the labs that Dr. Shapiro showed you and things that's big money. But I think we can get that money actually easier than this first 10. Because at that point, there'll be someone will look people in the eyes and say, we got a cure, or at least a path to a cure, and now we got to go from here to here. Right now, everyone's very cautious, and they absolutely have to be. But I would just ask our group here, if you've got if you got 10 million burning a hole in your pocket, let's write a check, let's go. Most likely not. but we know people, we all know people, and we just don't know which person is going to be the
Exactly.
one that'll step up and say, you know what, I'm interested to learn more. And that's where we come in, is to then give the information to the people and then help them make a decision of whether or not that's a direction they'd like to go.
Rob, I know how passionate you are about this organization and how many hours you give to it. Thank you so much for lending your perspective tonight and for all the time and dedication you give DRIFCan. We appreciate you once again joining our broadcast and speaking with everyone. Appreciate the time. Okay, we're going to move on now to a very familiar face and voice to many of you. Melanie Hibbard, who is the Executive Director of DRIFCan, the Diabetes Research Institute of Canada, mother of 2 boys living with diabetes. You've been watching, you've been listening. Welcome tonight. Let me know your thoughts after listening to everything that's been shared.
Well, thank you, Carrie, and thank you again for joining us for our 4th year. I remember when we started the conversation 4 years ago, when COVID was just starting, and we started having this conversation. How are we going to do this? What do we want to do? And, you know, most people who are watching this know our story, that we really aren't an event-based organization. We don't run big events. It costs too much money. We can't hit our 90-10 mark of a goal if we're running big events. But this event, we do it. It's a free event. And the reason for that is it's our way of saying thank you. Thank you to the diabetes community. Thank you to our supporters, whether in, grassroots, individual philanthropy, foundations, everybody, every penny that comes. You know, tonight we got a $10 donation from somebody, and their comment in it was, my daughter's been saving since her birthday, and so this is what she did. And so they made a $10 donation. It's stories like that. And we really are grassroots. But I'm going to say a but with that. So we're a grassroots organization. We're small. However, we're mighty. It's a volunteer board of 6 that are behind me as the executive director and the sole employee. But it's also all the people in the community and around the world that are starting to support us. And it's mind blowing to me what's happened in 2024. You know, we've gone from being a small Edmonton, Alberta, little organization to, spreading our roots into Alberta, and then all of a sudden spreading across Canada. And then we spread into the US with our partnership with the DRIF in Miami, which has been amazing as an international partnership. And then to being invited to go to the United Arab Emirates and going to Dubai and Abu Dhabi and meeting with research teams there. And that was huge for Dr. Shapiro and I to go down to, Dubai and meet with people. And why are we doing that? Because this Cures for the World. Canada gave the world insulin 103 years ago, and we are going to give the world a cure. And they know that. And to the point of Dr. Shapiro being invited to go to China and speak and collaborate, and to talk to researchers in the United Arab Emirates and to collaborate. The cure is expensive. Research is expensive. And this event is for us to really share what we get to experience, which is, every time I walk into the lab with Dr. Shapiro and that team, I get goosebumps. And every time I learn something new and I talk to the team, but at the end of the day, I have 2 kids with type 1 diabetes. I'm not just here because this is a career and because this is a job. I say it day after day. I just want to be unemployed. And when that happens, it'll be because there's a cure. This is not a job for me. It's my life. And I really want that to happen. So, for us as an organization, we've made strides. It'll be 10 years for me coming up since I've been with DRIFCan, and we couldn't do it without the community. So when I talk about fundraising and being grassroots and the communities around the world, but really in Canada, we have our group Humboldt and Area Type 1. I know that Kaylin and Jason and Maria are on here, and I'm sure a bunch of other people in Saskatchewan. And if you are on here and you're in Saskatchewan, please reach out to the Humboldt and Area T1D group. They're not just about fundraising for DRIFCan. They're about supporting the diabetes community in Saskatchewan. And I'll be there with Dr. Shapiro at the end of May for their event. He has offered to come and run with Jason for one leg of his 4x4x48 run. It's really, we've become a really close group of people, and I'm very fortunate that I get to know these people. But we have so many groups. I just want to say this quickly because I know there's so many people on here, and I'm following the comments, and I'm like, oh no, I got to comment on this, but from community support. It's the Building Trades of
It
Alberta
is.
Foundation. They support us. It's the cosmopolitan clubs across Canada and the US. It's the Lions clubs that help us. It's the Rock and August group that does a fundraiser here. We couldn't raise this year so far, and I'm so proud to say this, that we've raised just approximately $2.6 million in 2024, and we've hit our 90-10 mark for the 4th year in a row. So that means that over 2.2, 2.3, I'm not good with math. Rob's probably in the background smacking his head going, oh my God, what's your math? But, we're able to do it, and we're really proud to be able to show you with this event that the technology that's in that lab, your money goes there. You just saw where your money is going. So I know long-winded.
No, and I love the perspective you brought to the table with one answer. And I just want to insert a couple of things in there. You said something. You said you're small, but you're mighty. And the mighty, the perspective on that, everybody who's listening, is yes, you did go to Abu Dhabi this year and present there, and now to China. And we don't want this. And Rob alluded to this fact as well. We don't want DRIFCan and Dr. Shapiro's work to be the best kept secret, because you are connecting with so many donors now in the United States and beyond. And the very common answer is, why have I not heard about this? So we're going to shout it from the mountaintops. If you know someone who, tell everybody you know that has diabetes, that has friends with diabetes, that has family members. We need to spread the word of what Dr. Shapiro and his team are up to, because we're so close. That's the key, Melanie. You're seeing the interest from the international community. You've been there. So
we have to do it. And, I listen to Dr. Shapiro and the team talk, and it always gets me excited. I always go, okay, I got to think about this from a perspective from my kids. So, my kids are 25 and 21. They've had diabetes since they were 4 and 18 months old. We live this, we walk this, we breathe this for 21 years. But imagine this day, and everybody that's watching that has someone that has this disease, you go into, whether it's yourself or your family member, you go into the lab, you get your blood taken every 3 to 6 months to have your A1C taken to see what the average blood sugar is. But imagine you go in now and you go in and the blood is taken. So my kids go in, they get it taken, and they say, okay, we'll see you in 27 days, whatever it's going to be for the editing of the cells. Currently it's 27 days. And in 28 days, they call them back and they say, well, come back in. You know what? We've just edited your blood stem cells into islet insulin producing cells. And we do a quick drive-through transplant, for lack of a better word. That's really an in and out transplant in a day, or less than a day, a couple hours. And they're living diabetes free. And so, yes, people say, okay, but what about the system's going to attack it again? And then we're going to have to do this again. Well, the crazy thing and the amazing thing about this is it's autologous cells. They're your own cells. So it's limitless. We're not looking for donors. We don't have ethical issues with embryonic stem cells. This is real. And this is coming. And I know $10 million, everybody says only $10 million. And I think $10 million, we got to do this, because the faster we raise the money, the faster this goes into human trials, and the faster we get to the practical cure.
So with that, let's bring in the mind behind that to close out our podcast for the last 6 or 7 minutes here. The two of you have spent a lot of time together over, the last decade. And Dr. Shapiro, you said, you wouldn't be where you are without the support of DRIFCan. It would be impossible because there is no government funding.
DRIFCan and Melanie's energy has really built things unbelievably. When just before she came in to join DRIFCan, we went round the boardroom table. There were, I think, about 6 or 7 of us there, and we each had to open our checkbooks and write a check. There was no money. There was no nothing. There was a very small organization with a lot of drive, but nothing more. Melanie has learned from the grassroots up. She's proven her ability to do this. She came with us to Dubai, introduced me to a lot of people that I wouldn't probably have otherwise met. She's brought a lot of energy and vision to the table, and I can't say thank you enough to Melanie personally, to the DRIFCan board, and to Rob and his team. It's incredible what they've done, and they've built this lab, and I'm ever so grateful to you all. I know why you've done it. We are accountable to you. And indeed, Melanie's been to several of our lab meetings. She sits around the table. She has an equal voice. So we tell her what we're planning to do. She can share that with the board. We're happy to have anybody come and join us for a lab meeting. We listen to ideas. We share our strengths. We share our challenges, because there are lots of challenges in this work. And we are very determined to get to the next stage. But without DRIFCan, we wouldn't be where we are today. Thank you all so very much.
And to all of you watching who are making donations, some great comments here. If 1 million people donated $10, it would be 10 million, easy and fast. But getting that 1 million people to donate. She also wrote, I posted 2 and wrote 20 letters to 20 different individuals with type 1 diabetes and organizations that donate for health causes. Jason says, no matter how much time it takes to get to a cure, Dr. Shapiro, you're giving us hope. And that, you're giving us hope. Sorry, that just moved me. You're giving us hope, and that does make today better. So thank you. I think that sentiment is shared by so many people. And for those people who are interested and maybe they want to get involved in clinical trials of any sort, give us an idea of where they should go and what website.
Well, go ahead, Melanie. You do that.
So I was just going to say that for the patients, the lab does have a website, islet.ca. I'm excited to say that currently there's going to be a new website that's being developed right now for the lab team, and that'll be shared on that website so that we know where they can send things to. But it'll include things like the new video that you just saw prior to this, that to help, DRIFCan helps support the making of the video, and we help support making of the website, because we know that we've got to get the information out there. And the more that people see in real time in the lab, they're going to be more inclined to give. So we needed to make it so that people can look from around the world. But from a patient standpoint, that's where they can go to talk to the team.
Dr. Shapiro, you had something you wanted to say as well.
No, I was going to just say the islet.ca for now, and we've got a new website coming that Melanie's building.
Sorry.
Closing thoughts tonight. Should we, let's see if we can bring back the whole team onto the stage. And friends, you can see everybody who is involved and working so hard to help change lives in every possible way. So comments, closing thoughts from any of here's a really nice comment I want to share. For many years from Catherine, I have been hopeful that there will be a cure during my kid's lifetime. And this presentation has really given me the hope that this dream will come true. Many thanks. How does that make you feel?
We've got a lot of responsibility on our shoulders. We've got an amazing team that you met tonight and met previously. The fact that they're here at 7:30 at night in the lab doing this speaks volumes, but they're also here crack of dawn as well. So I have to thank this team for the incredible hard work that they're doing. There's a big need. We recognize that. We have a lot of responsibility on our shoulders, and I'm so grateful to you all tonight, to DRIFCan, to you, Carrie, for putting this together. We will get there together. We're a global team, and we will get there together.
D-Mum says, my hope has been revived and I feel uplifted. Let's keep going forward. Thank you to the team and DRIFCan. Jessica says, thank you all so much. Also hopeful that my son will also find a life without type 1 diabetes one day. Sari says, thank you all so much for your hard work. We feel hope. On that note tonight, it was an uplifting conversation. I'm grateful to you all for taking time out of your evening. I know how the hours, I think I know the hours. I probably don't really know the hours you all work. But on behalf of everyone watching, I would like to extend my heartfelt gratitude to each and every one of you that are working in a variety of capacities to make this change real, because I meant it when I said it. I am hopeful too, and I believe with all my heart and my soul that one day I will be telling my older children and my grandchildren, can you believe we used to treat diabetes with insulin? Wow, it's crazy. And they would go, wow, really? That's cured now. It's cured. that narrative is going to become very real, very fast. So to all of you, on behalf of all the viewers that are watching tonight, the thank yous are coming through fast and furious, trying to click on as many as I can. Thank you for all your incredible work and what you are giving back to not only individuals, the community, but to the world. Thank you for your dedication to this goal. I'm not going to call it a dream. It's a goal, and it's a goal that's going to be realized very, very quickly because of you. For all of you watching that have donated, thank you for sharing your hard earned dollars with DRIFCan. We appreciate you. And I think on that note, I will end by saying, if you haven't made a donation yet and you still feel inclined, or if you know that person that has that $10 million, tell them to go to DRIFCan.com, and they can make a difference there. And every dollar counts, as Melanie alluded to earlier. I'm going to say goodbye to all of you, and I think it would be an appropriate way to end this broadcast tonight with sharing that video one more time, because it is powerful and it is emotional as well, and it brings everyone up to date on what you've been working on. This is a beautiful comment to end with. Thank you so much. I cried about 10 times tonight. You are so important to us all. Your hard work is appreciated. We appreciate you all. To all of you who gave of your time tonight, thank you for watching. To all of you at the Diabetes Research at the University of Alberta, thank you. To DRIFCan, thank you. Thank you all for watching tonight. I say good night to you all. And with that, Dr. Shapiro, we appreciate you more than words can ever say. And to you as well, Melanie, incredible to have you on leading the charge. And there's not enough gratitude. So with that, we end with this video. Thank you for watching, everybody. Enjoy your evening.
Completely focused on building stem cell therapies to treat diabetes in patients. 25 years ago, we did our very first Edmonton Protocol patient, Brian Best, a teacher who really couldn't function because he had such severe hypoglycemia. He'd been in the middle of a class and basically faint. We gave him one islet transplant and his blood sugars improved dramatically. His insulin requirements reduced by half. That was unexpected, that the first patient would be able to come off insulin. There'd been 273 islet transplants done in the world, and very few of them worked. I did not think the Edmonton Protocol would be any different. And stem cell therapies have come an awfully long way in parallel with the advances in the Edmonton Protocol over the last 20-25 years. Stem cell therapies can either be patients' own, which is our interest, but we know that's the most ambitious research you can do. You can also make banks of cells that are not patients' own, what are called allogeneic. And what this means for us is that we can now potentially make patients' own cells using stem cells, and we can take a blood sample, that's what we're working on in the lab, from a patient with type 1 or type 2 diabetes, or a patient even that's had surgery and had the pancreas removed, and we can make islets from the blood. It's a very complex process. It involves taking the white cells from the blood, de-differentiating them in a process that makes them into what are called iPS cells. So the question now is, how can we make this kind of treatment, the Edmonton Protocol, more available and more appropriately for patients with less severe diabetes? And our team in the lab is a fairly small team. Dr. Deach and Rena and Heidi and our technicians and graduate students are working incredibly hard to try and solve this puzzle. We work very closely together. If I look back, that team's been working on the stem cell side of it now for about 6 years. We have made phenomenal progress because we began that process from scratch, built a new lab from scratch, and have been able to master the techniques now over the last short while. But that work continues, and it's tough work, but we have to do that in order to reach the first patients. We're continually peering over the cliff face, saying, how can we fund this kind of work? We know it's going to work, but we need that proof of concept. But this is exceedingly ambitious. So we certainly need philanthropy as well to give us the flexibility to move with the ideas as fast as we can as we try to take this stem cell therapy to the clinic.
We're on track for human trials to begin. It's expensive, but with your help, we'll get there soon.